So peg feeding, basically, we're talking about the digestive system here, and we're trying to get food into the body. And obviously, this is really important for those that maybe have had surgery or there's obstacles to do with the mouth or even the throat, which puts people at risk. And therefore, actually, a peg feed is a way of getting food and nutrition and medication into the body. Now, obviously, as we go through this, there's lots of risks to peg feeding. So risk of infection, because you're directly putting something into the body. The stoma site, so you can see on that first picture, you've got that little yellow circle, and that's the stoma site where the tube is going into the julian, into the body, into the bowel. Or alternatively, you might do a nasal one, and again, it can cause obstructions to airways, etc. So we just need to be mindful around lots of risks of infection control. And equally, as we deal with peg feeding, let's just think about that moment of being sensitive and obviously dignity, because again, it can feel quite undignified using those. So just a bit of care and compassion. So we're not going to run over housekeeping. We don't need to do health and safety. Policies and procedures, it's important that you read up on your services, policies and procedures regarding peg feeding. Each service will have a different way of doing something. So it's really important that before you support somebody with peg feeding, you've seen and read your policies and procedures. Okay. So the aim of the session really is to have a basic understanding of what gastronomy is and how it works, and the care that with your client, and obviously to support them to manage feeding through a tube. Okay, so that's what we're hoping to get from this. By the end of this, you'll be able to describe different types of feeding tubes, so the 3 different types, define how to care for the client with the tube with regard to hygiene and skincare, identify possible complications, and explain how to administer feed and flush safely. On the Canvas site, you've got videos to watch as well. So the more you watch, the more it'll make sense as we go through. And obviously, identify the implications of administering medication through a peg feeding technique. So we call it external feeding, and that's because many clients are unable to eat but require long-term nutritional support. They may be achieved through the incision of external through, so via the digestive tract, feeding tube, which will also enable them to receive nutrition medications they need in order to survive. So it is something that's done as a last resort. People don't normally go, let's go down the peg feeding route, because there's lots of ethical complications here around consent and capacity and choice and rights, etc. Okay, so you've got 3 different types of peg feeding, or extended feeding, sorry. So you've got directly into the stomach. So that's our typical peg feed. So we're going to go straight into the stomach. And the benefit of that, obviously, is if it's going into the stomach, the digestive system is still working properly because the food is going into the stomach is still creating acids to break it down, and it's still being passed around the body. So therefore, actually, it's quite easy to recover from that. You've got the, I can't ever say this, the bowel. So in the bigger bowel, you've got that, so it goes into the jejunium one, so into the bowel, and obviously that's just an incision, stoma site, into the bowel. Now the problem with that is it misses part of the digestive system. So the problem there is we start to lose that bit around the stomach. And the thing with the stomach is it's what sends the signals to the brain that you're either hungry or you're not. So imagine not ever having food in your stomach. You're going to have that constant feeling of hunger, because at the bottom of your stomach is the nerve that sends to the brain that you're either full or not full. And if that nerve is taken away, you have to learn to control it via the signals of your body. So when you start to shake, that signals that homeostasis, the sugar levels are dropping, I need to eat. So again, it's possible. And when people have stomach surgery, so let's say they've had a sleeve or part of the stomach removed because of cosmetic reasons, again, normally what happens is they get rid of that bit of the nervous system, so you're never hungry, you never feel that you need to eat. And then obviously you've got that, so that's the PEJ, and then you've got the nasal one, so that's the tube that just goes up and down into the stomach. Again, quite easy, and a lot of people are able to insert those themselves. They're quite easy to feed in and take out. So we've got our 3 ways of entry points into the body. So we need to obviously think about the clinical need there. We need to think about the duration of the feed, to how long it's going to take for the food to pass. We need to look at the function status of the GI tract. So that's the gastric tract and everything connected with the digestive system. We need to look at the potential for aspirations. What happens if they start to choke or they can't bring something up and it gets blocked? And obviously the comfort and safety of the individual. So as we're doing this, are they sitting comfortably? You know, are they laying down or sitting up? But generally they should be sitting up in an upright position, as you would normally to eat. You know, we normally sit up to eat, and that's what helps the body digest and understand what it's going to eat. People that may require external feeding. So you've got lots of reasons there why people might need it. So head traumas, neck traumas, gastric surgery. So you just need to bypass the gastric bit just for a while. Maybe they've had a stroke, burns, trauma. Maybe there was a genetic something, or cerebral palsy, and any diseases that are kind of linked to malnutrition. Okay, so there's lots of different reasons why we might have peg feeding or extended feeding, sorry. Prior to the external feeding, an assessment should be carried out. The assessment should look at the individual's nutritional status. What assessment tool should we first then use for nutritional status? Do you remember the one that I told you all last week?
Nutrition assessment, no?
Yeah, it's a nutritional status. What assessment tool would we use to assess the nutritional status of somebody? Begins with M. Ends in score. No, it's fine. It's the MUST score. So if we do the universal male nutritional scoring system, we get an idea whether somebody's overweight, underweight, and what the risk is associated to that. And normally on a MUST score, if it comes up as high risk, the first thing the MUST score calculator will say is this needs to be referred to a dietitian immediately. So you wouldn't wait, you would just get on with that straight away. Obviously, the oral care assessment. So if food and fluid isn't going in our mouth and down our throats, we need to think about the hydration of the mouth. So again, the mouth should naturally be producing saliva, so the saliva glands are still working. There's that swallow reflex. So again, thinking about how we're going to maintain that care of the mouth and tongue. Equally, if we're not producing the saliva in our mouths, then the problem there is we can end up with infection, thrush, and bacteria and ulcers. So again, it can turn quite nasty quite quick. So really good oral hygiene there. Swallow assessment should be done. So that would be done by the SALT. They'll come out and do that. And again, it's just to make sure. So when we swallow, if we ask somebody to swallow, you should see the gag reflex and the muscles in the neck go up and down. So as long as we're swallowing, okay, someone's got a terrible mind there. As long as we're swallowing properly, we know that everything's okay with that. Infection control, obviously thinking about infection not only to the mouth, obviously to the stoma site, or either the nasal passages there. The individual's psychosocial needs. So again, how's this going to affect them going out? What does it look like if they want to maintain a normal life in community? How's it going to do every part of their time? Because let's not forget, CQC's requirement for supporting people to eat and drink is meant to be a protected time. It's meant to be an enjoyable experience where you bring people together and they enjoy the social interaction of each other. And when you think of other countries like Greece, for example, meal times is a big thing. It's about family and bringing people together and just talking. So if you've got somebody who's being taken away from all of that, what does that look like? How are we going to stimulate them? Obviously, you need to give people information, and same thing, if you're going to put food into somebody's body, you still need the consent about what you're going to be putting in. The only time that we would override that consent is obviously if they're on best treatment or if they're under a care plan treatment order. So, you must do this to sustain life. And then obviously we need to look at any additional help that's required. So who cares for the external feeds? The individuals themselves can do it. There's no reason why people can't set up their own machines. There's no reason why people can't do their own bulbous drops. It's down to the client and their choice, you know. And if you think about our enablement model, we should be promoting their independence to maintain their own healthcare needs. Family members are normally the ones that do it, especially for children. Healthcare providers can do it, or multidisciplinary teams. The reality is, whoever does the feeds or supports people to eat needs to make sure that they're aware of what to do if there are complications and what to do to preserve life if something happens. So again, it's really important that they're aware of basic life support. And you know, we will do that. It's another module, and I know you will know CPR and all that, but again, we have to do it. And equally, it's just that infection control bit. So whilst it's not aseptic, it's not, you know, it needs to be massively sterile. It does need to be normal food hygiene principles apply. Okay. So we've already done a little bit about this, so we don't really need to go into a massive amount there. But obviously, you've got your esophagus at the top, going down to the stomach, the small intestine, the large intestine, and then the colon and the rectum at the bottom. See what I do when I can't do the Latin words? We just call it what it is. You don't need to know everything by the Latin terms. Okay. So really, you're looking for short-term for up to 30 days. And that's normally the nasal one. So if we're going to put a tube up in the nose and down into the stomach, it's normally short term, and it's normally for a recovery thing. So you've left hospital and actually we just need to get you back on your feet. Longer terms, you would then look either through the stomach or through the bowel. So you're going to have one slightly higher up or lower down. And again, the position of the stoma gives you an idea of, are you going directly into the stomach or directly into the bowel? So that's what you're looking at. Short term, normally nasal, long term, 30 days. Problem because of COVID, I have known now patients to be having them in for up to 60 days and a bit longer. Obviously, that's not what the NICE guidelines say. So after 30 days, we should be doing a reassessment, because the longer we use it, the more at risk the customer is for losing the swallow reflex, for not producing the right glands and not having the right muscle control. So the longer we have the one in the nose, the more at risk the person is for not recovering properly. So there is real benefits of being quite firm with this and going, look, actually, if after 20 days we're not seeing massive improvements, we should be getting them reassessed and trying to look at what is the next solution. So we've talked about different types. So this is the PEG one. And you can see here, down at the bottom, you've got your before and after. And basically, it would be day surgery. They would go in, they would have their stoma site put in. And again, when we talk about stoma, we're talking about the circular bit of the flesh that's removed for a port into the body. And we talk about stoma when we do stoma care later. So it's still a stoma site. And again, what happens is the button goes in, and no different to a catheter, the tube goes in and it's got the flexi part and the ball at the bottom where it's then inserted with liquid, no different to a Foley with a catheter. Okay, so it's a similar port in. So that's what that one looks like. Now, you're not allowed to, and nurses don't normally put those in. They normally have to go into hospital. So if that comes out, it is a hospital job. They have to go to hospital to have that put back in, okay? And that's because of the infection side and making sure that it's gone in and it's gone in properly. Because unlike a catheter, you know you've got it in properly because it won't come out and you normally get urine coming out. In this one, you can't see where you're putting it, okay? So it's really important. If that comes out, you normally patch up the site and get them off to hospital and get it re-put back. So you can see there what that looks like. Obviously, it's done with a camera. So they do the endoscope, the Foley goes in, the gastric tube fills up, and you can see, obviously, on that picture, it goes through, obviously, all the free laser skin and directly into the stomach, and needs to be done under X-ray. So that's why you can't do it.
Can I ask something? Sorry. I want to ask what food, how you get the food into that, or what, with the injection, liquid, or
So yeah, all the food is liquid. It's not very interesting because there's no flavour to it because it's void in the mouth. It's like those milkshakes. It's like the build-up drinks. They're just high in proteins, high in vitamins.
Through the, I just don't get through the mouth, and it's going into the tube, or?
Yeah, you'll see in a minute. You'll see the different ways of the food entering through the tube. But obviously, it's really important that you only use the meals that are provided with those techniques, because again, different thicknesses of the liquids going in can cause other problems. And equally, that flushing and keeping it clean. So if you think about our mouth, when we eat something, our brain sends the signal, oh, that smells nice. And normally we start to salivate. Our mouth will naturally fill up with saliva, ready to break that down because it's the first stage. Obviously with this, all of that's gone. There's no enjoyment. It's food in to sustain life.
Thank you.
So with the gastric, with the peg feedings, you'll normally get a port. So this is what the port looks like. Slightly different. You can see it's just a little tubey bit. And at the bottom, it's got the balloon. And obviously that it's quite lightweight. It's quite easy to clean, quite easy to change. But again, we wouldn't be putting ports in. Okay, what we're interested in is just making sure that the port and the button is clean, it's not got contaminated, that the area of the skin around is clean, it's not red or inflamed, that there's no smell, because if you can smell it, it means there's an infection. So again, just making sure that it's looked after properly. And obviously, these are quite dignified, they're quite small, they're quite discreet. So actually, from a dignity point, these little buttons are quite useful. So again, gives you just an idea of what that looks like going in. Normally they're replaced approximately every 6 weeks. So again, not too bad, but quite distressing for the person constantly doing it. And obviously the balloons are then inflated with saline, no different to what you're going to see for catheter care. So I don't know whether that video is going to work. Can you see that? So this is an insertion, and this is why it needs to be done. So obviously they're preparing the site for the button. So they're feeling for the stomach. Again, you can see where they're pushing down on that. You can see that that's the stomach, so they've got the right site there. So applying local anesthetics. So this is done while they're awake. So they just make a piercing, and obviously that's to make sure they're in the right place. That's the gastric tubing. This one they stitch into place. So this is obviously a lot more invasive than that button, because the button just goes in and inflates. So this one that they're stitching it in, so it doesn't move around so much. That's the stoma cap, so that's the port site. And obviously what he's doing, he's just popping that on the thread so he can now pull that through. Just like, okay. So you can kind of understand if that comes out why it's straight in an ambulance. Okay, so that's now the port in place. And obviously that wound is stitched up around. There. Happy with that? So it just gives you an idea of what it looks like.
Very interesting. Mm.
Yeah, it's fascinating to watch because it just gives you a bit of insight of what somebody has to go through when they have this one. So obviously the one that goes into the bowel, they used to feed beyond the stomach into the upper end of the small intestinal tract. It's used to obviously for individuals who can't absorb nutrition through the stomach, and obviously that's the J tubes, and they're not normally rotated, so we don't twist them and turn them and all that lot. So once they're in place, they're in place. So your nursing interventions are all about skincare first. So making sure you've washed your hands and that the stoma site is clean and dry. Two reasons: if they come out of hospital, first of all, they've got that stitching, so the wound actually has to heal first of all. And if that's constantly being pulled or tugged, it takes a while for the skin to repair. And equally, if food particles get caught or there's leakage, then again, it's going to keep, the wound isn't going to dry and it's not going to heal properly. So there's lots of risks of infection here. So it's really important to make sure that if there's padding around the stoma site, because what normally happens is you've got your piece of gauze and you would cut it and then you would slide it around the site just to keep it nice and dry. And obviously, making habits of inspection that skin daily. To be fair, I normally do it after the feeds because I want to make sure that there hasn't been any leaking. So I would always do it after the feeds. And obviously you're looking for signs of infection, redness or swelling. Any of those are, obviously you need to call somebody because that infection needs to be dealt with. And yeah, so daily cleanse of a new stoma site with sterile water and gauze. So that's all we're looking at. So it's normally those saline waters you get for wound care. You just squirt them in and give that a little wipe around. Obviously, you need to make sure that you clean the devices. So if you've got the machine where it pumps it through. So the machines look a bit like a syringe drive. It kind of clips in a box. And again, you'll see that on the videos. And when I come out, I'll bring the machines with me so you get to play with the machines. They're not difficult to use. And obviously, there's loads of instructions there. And obviously just making sure the stoma heals and that's been cleaned properly. And again, once it's fully healed, then they can do normal routines. Okay, so they just need to make sure that it has fully healed before we start dunking them in a bath. And don't use creams or powders around the site because it is an open wound, it will go directly into the body. So no creams or powders. Mouth care we've already spoken about. It's really, really important that we maintain good oral hygiene. You know, they still have constant visits to the dentist, still cleaning the teeth, And if they're nil by mouth, regular mouth washes can be quite nice. So just give them to spit. And the other thing that can be quite pleasant is ice cubes. So if somebody's got that dry mouth and it's cracked, give them an ice cube can help kind of just relieve. It's not a lot of water that's going to go in. So again, that's a useful thing. So care with the individual, obviously if it's hand washing, carefully handling the feed and the equipment, avoid touching any of the parts of the equipment. So any of the bits where you're going to put the food directly into, and you'll see that in a second. Making sure that everything is kept nice and clean. So again, if you're going to be opening up the food containers, sometimes they've got packets, sometimes they've got a piercing pot, sometimes they've got like a lid. So it depends on what it is. Just be mindful that if you're going to use a pair of scissors, are they clean? No different to you preparing food in the kitchen, just make sure that the stuff's clean. And it is solely for that. And obviously all feed plastic parts should not be reused. So it's all single use. So what you should see is a circle with a line through it and a number 2, meaning single use only. Feeds can be hung up for 24 hours after opening. So again, if you can't use the whole amount, you can go back, obviously, food safety principles, you can put a lid on it and date it and it goes in the fridge. If you do put food in the fridge, it's really important you date it. You must date when it was opened and the time, okay? So that's really important. And obviously everything that you use, so the syringes, the measuring cups, all the equipment needs to be washed and cleaned like you would normally wash and clean stuff. So you can use the syringes more than once for peg feeding because they're normally the biggest syringes. They're normally the 60 mils, they're quite chunky. But again, good principles of washing and cleaning the equipment and obviously making sure they're air dried correctly. No different to what you would do washing up. Care of the tubes. So making sure that the tubes are cleaned and flushed regularly. So if you're going to give a feed to somebody, if you're going to give medication, making sure that you do a flush with water before and after, because again, it's no different to our mouth. We're preparing it with water to say, look, something's going to come and I'm going to clean it away. And afterwards, I'm going to flush it to make sure that there's no food particles left in the tubes. So flushing is really important. And obviously, making sure that the balloons are filated to its right volume so it doesn't fall out. So if it has got the balloon, like the Foley bit in the balloon, making sure that that is right is really important. So what do we do if the tube comes out? Obviously, remain calm, place a dressing over the stoma site, contact the hospital or your agreed healthcare people, and obviously get the person to hospital to have it replaced. Okay. So problems in which you could face, lots of problems there. So you could have infections, pressure sores, you can have skin breakdowns, you can have overgranulation, so that's where the skin starts to heal and it tries to heal over and up and around the site. That's not very helpful. Allergic reactions, so again, looking for those patches of skin, dry bits. Blockages, if the tube gets blocked, don't panic, do a flush. And lots of other things. The balloon may burst or leak, but then it will come out, so then that's go back. Rapid weight loss or rapid weight gain. So you must be doing regularly weights. So again, must score, constantly weighing them, making sure that actually they are benefiting from this, or if they're not benefiting from it and that weight loss is still happening, how much are they losing? Do they need more? Do they need a more fortified supplement or something? Obviously, gastro disturbances, because that's not working properly, so they could feel like they're getting lots of refluxes and stuff. And other issues there. So lots of complications to think about. Checking and storing the feeds of the food. So again, no different to normal food safety stuff. Just make sure it's in date, make sure it's being stored correctly. Some are stored in a fridge, some are stored at ambient temperatures. So it just depends on what that meal is that you're going to give them. Check that it's been prescribed by the dietitian. So make sure that it is the right product because obviously it's personal centered. Check the expiry date, store it at the right temperature, avoid placing near radiators and fires, and obviously don't leave it outside. You know, just store it as you would normally store food. And obviously open feeds can be stored in the fridge up to 24 hours. So how to use the feeding tubes. There's 3 ways in which you can get food into the body. So this is the bit where you're like, oh yeah, this is the bit I wanted to know. So it's important that you have your equipment. So you need your syringes, and that's the 60 ml syringes. So this is the big syringe. You're obviously going to flush regardless whether the technique, you're still going to flush. And then there's 3 ways of getting it into the body. So a pump is the machine, okay? And it's no different to a syringe drive or an IV from a hospital. You set your feed up, it goes through the machine, and the machine will send it into the body at a certain volume and rate. It beeps and it tells you when it's done, job done. So it's really nice and easy, that. The gravity bulbous is basically, it's like a syringe, but no plunger. So you hold the syringe upright, the tube is connected to the bottom of the syringe, and you just pour it in the syringe. And because it's gravity, you hold it above the site and the food just trickles in that way. Okay, so that's a gravity bulbous. And a syringe bulbous is the feed comes in the syringe and you just inject it into the site through the tube. Okay, so there's 3 ways in which you can support somebody to eat. The most common used is the pump. It is the most common. I don't actually ever see the others. However, it's really important to know that there are other techniques, because if your pump breaks, you've got another mechanism of getting the food into the body. Okay, it may not be your preferred method, but it is a method of getting that food in. So the pumps are electrical devices. They normally set by an hour or time, and it just releases the food into the body. And obviously it benefits because it doesn't need that member of staff to stand there and hold or support that. Ensure the individual is seated or laying correctly. Normally, we kind of lean them back into like a W position, so their body's ready to receive the meal. You set the feed up per the instructions, so no different. You know, if it says 20 meals over an hour on the buttons, you just push the button and set it. Okay, and obviously make sure you follow those instructions, and you'll see that on the videos in Canvas, and you'll see it when I come out. So this, can you see down in the corner of that picture? That's the machine. And basically that white cap lifts up. You put the tube around the wheels that turn, close the cap, and you just set the timer. It really is very, very simple. And again, when I come out, I've got this, I'll show you how to use it. And again, we'll just a clinical bit and then you can practice. And it's all about just making sure it's connected properly, you flushed it and it's working, that the individual is comfortable, and that you document what you've given. And you can see here in this picture, it's got the bag. So that's a bag of food that hangs up, and basically the tube's got like a piercing and it just goes in like a cap, like a straw. It's like a Kappa drink with the straws. That's what it looks like. There are other ones where you've got the containers and you just pour it in the container and then it runs through the machine. Same old, you know, as long as you've got the device for the fluid to go in. And you can see it looks like a milky substance drink. Yeah, wouldn't want to drink it, but that's what it is. The gravity bulbous is rarely used, but it's required for a slower administration. And this ensures the individual's positioned correctly. So again, they should be in that W position, slightly leaned back, but upright. Obviously, you attach the tube to the tube. So you would attach your bulbous, the container to the tube, and you would flush first and then obviously follow through. And you can see there in that picture in the bottom right-hand corner, that's what a bulbous, gravity bulbous feed looks like. It's just the tube, you're pouring the liquid in, and you can hold it and release. So what you'll find is the higher up, the faster it goes, the lower down, the slower the feed. So you can control the speed. And equally, if you're thinking it's going too quick, you can always put a kink in the tube to slow the feed down a bit. Because again, you don't want it rushing into the body. It needs to go in at a nice controlled pace.
And you not squeeze the tube,
You can, yeah, absolutely. So you can squeeze that plastic. Normally what we do when there's tubing involved, if you just kink it, bend it, it stops the flow. And sometimes what you'll get is those little plastic clips that are on the tube, so you can roll them to slow down the speed at that. Obviously, oh yeah, the roller clamp. So yeah, you've got the roller clamp there to adjust it, and obviously the height will make it go quicker. And again, you're just making sure it's the prescribed amount. So it's no different. The only difference is you're doing it manually versus machine. Okay. And then finally, the syringe normally contains 15 mils of the feed, and you're going to directly, rather than that bolus, you're going to directly syringe it into the person to make sure that they're getting the required amount, and obviously documenting it. So you can see there, that's the syringe, and all you're going to be doing, same thing into the tube, you're just going to inject it. So when we do medication through the tubes, what do you think the problems are with medication?
I think it has to be crushed.
Yeah, absolutely. So different medications, the moment we start crushing meds, we change the pharmacology of the medication. So
It has to be liquid, probably.
Yeah, absolutely. So a lot of the time, if you're going to put medication into a feed, you would want it to be liquid. You would want the doctor to prescribe liquid where possible, because it makes it a little bit easier. The problem that we have with some of the liquids is the thickness of them. And if they're a bit tarry, it can cause a problem, because it can cause a stickiness in the tube, and that can be a real problem. So just making sure that actually, if you have got something, it is prescribed and it is safe to administer via a tube. Equally on the powders, so if you crush a tablet, the problem that you can have is it can congeal. Sometimes it can come out a bit lumpy, so you've really got to mix that in. And equally, if we're going to do meds, it's one medication, you crush it, so you flush beforehand, you put the medication through, you flush after, and then you do the next tablet. So you can't put them all in at the same time. And there's a couple of reasons for that. One is around capacity and consent. The reality is I may not want all those medications. I may only want one or two. And if you've crushed them all and put them in, I've got no choice. So that's the first problem. The second problem is the pharmacology. If you start mixing tablets, are you changing how they're absorbed in the body? So we're going back to pharmacology, the basic principles of tablets. So it's important that we do one at a time.
Sorry. I've got clients which they just take all the medication in one go.
Yeah, and that's fine. Yeah, absolutely fine. The reality is, when we orally take medication, the pill is designed, or the tablet is designed for the release. So if it's got the plastic on it, the cap, it's normally slow release because the cap has to dissolve. If it's a tablet and there's no sugar coating, it's normally a quick release. So by the time that's released, the cap is dissolving. So they still go into the body at different rates, where obviously if you're going to take the plastic cap out and tip that powder in, you've automatically changed how the body absorbs that medicine. So it's just a case of making sure you're following the right principles. You would hope the doctor gives you the right medication.
And what happens if, because I've got another client which she's got a capsule and she likes to break it down before she swallows, and so, with other medications too.
Yes, so again, it's basic principles of pharmacology. If you're changing the way that the medication is prescribed, you are changing the way that it's absorbed in the body. Now, the reality is those capsules are designed as well, because it may be the fact that the medication could be toxic or could cause thrush to the back of the throat. It could be absorbed in the wrong place. It's not designed to be absorbed through the bloodstream. It's designed to be absorbed through the stomach. And actually, if you're breaking that capsule down, you're absorbing it through the tongue and the throat. And what we know is in medication, we absorb it quicker in our cheeks and mouths than what we would through the body. So when we give something like Epilim or a benzo injection for epilepsy, we give it in the cheeks because it absorbs into the bloodstream quicker. So if you're breaking a tablet down, you're absorbing it at a faster rate than it is prescribed.
And is there any risk I should tell the doctor?
All medication comes with risks. Again, it would be the case of looking at the BNF So if you look at the B&F manual, and you can do the B&F as an app, you can download it on your phone, or you can do it online, and you can just check that medication, see if it's harmful to be taken that way. Okay. Sometimes they're not. It just depends on what the medication is. Yeah. But that's, again, basic principles of pharmacology. So just when we think about medication, they are designed in a certain way to interact with the body in a certain way. And it alters the moment we go to something like this as well, because we are changing how that medicine is given. And that's why concealing medication, hiding it in food and drink, you must get the consent from the doctor, because actually it could be harmful in you doing it the way that you do it. And you won't know, because there's so many combinations, you know, and again, if you mix two drugs together and you crush them, you could have created a new super drug. Mm-hmm. We just don't know because we're not pharmacists. But anyway, must follow normal policies when doing medication. Obviously, check that the medication should be given and encourage them. Medication should not be added to a feed. So when we do medication, we keep it separate. It is a separate process. People are tempted to add it. The problem there again is absorption. If you're putting medication into food, some medications need to be given before food, some medications need to be given after food. So you must give it as it is still prescribed. Yeah. And again, if you put medication directly into an empty stomach, are you going to cause a stomach ulcer? Is that sitting there dissolving unnaturally? Because those capsules protect the stomach lining as well to make it safe for it to be absorbed. So again, normally you'd be given an omeprazole, so those anti-acid tablets. So anyway, we digress. Liquids or soluble tablets are preferred as opposite to obviously the crushing. So if you can't get liquids, can you get it as a soluble? Will it just dissolve naturally in water? Because that's what you want. The real last approach is crushing the tablet, and that should be, all right, there's no other choice here now. So again, if you are responsible for some of this medication, try and do liquids and solubles, because they flush through the system easier as well. And when you look at how thin that tube is, getting medication through that can be quite tricky. And obviously, if crushed, the prescriber or the healthcare worker must accept responsibility for any adverse reactions. So again, you don't know that what you're doing is creating a new superdrug, and therefore you don't know that you're not going to get an adverse reaction. So it's important, if you do it that way, you observe them for 15 minutes afterwards to make sure that there's no obviously anaphylactic shocks or rashes or whatever that's going to happen. And we normally know after medication is given into the body, after 15 minutes, if there were going to be an adverse reaction, it would happen within that 15-minute window. Okay, so medication then. Obviously hand wash, stop feeds, flush with 30 ml of water. So we're going to flush the tubes, we're going to inject water in, we're going to clear it, and then we're going to prepare each drug separately. Now, I have had a patient who was nearly on 20 different meds. It takes a long time because it is one medication at a time. You can't mix them and do it all together. And again, in between each medication, you are flushing. So after each med, flush, next med, flush, next med, flush. So it can take a long time. And actually, it's really important if you do have somebody on peg feeding that that's put into the care plan. People are aware that this isn't a job you can rush, because I know how busy you all are. But this is a job that, unfortunately, if it's not done properly, has quite a lot of risks and consequences. Right, oh, peg feeding video. I don't know if that's going to work. Let's have a look.
Gracie is an active 14-year-old, a cheerleader with lots of friends and a zest for life. So when she was diagnosed with a condition that required a feeding tube, she took it in stride pretty easily, and so did her mom and dad. In fact, most people, children or adults, adapt quite easily to the use and care of the Mickey low-profile feeding tube, just as Gracie and her family did. The Mickey low-profile feeding tube is made by Kimberly Clark, a leader in enteral feeding tubes and a well-established name among healthcare professionals. The Mickey feeding tube has many features that are important and worth noting. Let's take a look at some of those features. Low profile means that the Mickey tube is designed to lie very close against the patient's body. The size of the stoma and tube are carefully matched by the doctor for a proper fit, which minimizes restriction on activity. This is the distal tip. It's tapered so that insertion into the stoma tract is easy. This is the external bolster. It helps hold the tube in place. The slim design allows more air to circulate around the stoma site and makes it easy to care for. Another special feature of the Mickey feeding tube is this little balloon called the retention balloon. It also holds the Mickey tube in place within the stomach and secure in the stoma tract. The balloon inflation port is used to inflate the balloon. When the balloon is inflated to the proper size, the external portion of the Mickey feeding tube should float just above the skin, with a space about the thickness of a dime. The Mickey kit comes with several important accessories you'll need to get started with feedings right away. It includes 2 types of extension sets for 2 types of feeding methods. One for continuous feeding, where the feeding is administered with the use of a pump and over a longer period of time. The other for bolus feeding, where feedings are periodic and usually of short duration, like breakfast, lunch, or dinner. The doctor decides whether bolus or continuous feedings will suit the patient's nutritional needs better. A few years ago, Gracie's doctor recommended a Mickey feeding tube for Gracie's supplementary feedings. She was delighted to have a feeding tube that didn't stick out from her body. Now she's perfectly confident setting herself up for her 6-hour continuous feedings. As she would say, it's no big deal. To complete your tour of the Mickey feeding tube, let's look at a few more important features. This is the feeding port. This is where the extension set is connected. This is another very helpful part of the Mickey feeding tube, the anti-reflux valve. It is located inside the feeding port, where its job is to help prevent the stomach contents from leaking out when the patient is not feeding and the extension set is not hooked up. Here is the feeding port cover. It prevents bits of formula, you might call it gunk, from accumulating inside the feeding port and valve. Here you see the Mickey feeding tube connected to the extension set. This is the secure lock connection mechanism. It allows the tube to move around so it's more comfortable. Now that you're familiar with the parts of the Mickey feeding tube and you know about the 2 different extension sets used to hook up for a feeding, let's walk through a typical feeding procedure from start to finish. It is simple and logical. It'll be second nature to you in no time. Before you do anything else, wash your hands every time. This is very important. Before feeding, use a small amount of water to flush and pre-lubricate the extension set and tube. Be sure you check the Mickey feeding tube before each feeding to make sure that it's still in position. It's a simple procedure. For details, consult your guidebook or ask your nurse or doctor. Now that you've done the prep, let's see how a feeding setup works. Just follow these steps. Using the appropriate extension set as your doctor has directed, connect the extension set to the Mickey feeding port. Align the black line on the extension set connector with the line on the feeding port. Push it into the anti-reflux valve and turn it clockwise. To disconnect after feeding, realign the black lines and pull out the extension set connector. If your doctor has prescribed continuous feeding, connect the continuous extension set to the stepped connector from the feeding bag with a firm push and twist. Wetting the stepped connector before insertion may provide a more secure connection. For bolus feeding, connect the bolus extension set to the catheter tip syringe with a firm push and twist. Finally, your doctor may have recommended that you check for proper placement before each feeding. For more details on how to do this, refer to your care guide or contact your healthcare professional.
Camp Wackenhack? That's a fun camp. Most of my friends go there. We have kayaks, we have archery, we have biking. It hasn't interfered with anything at all. Nothing I can think of. Swimming, if you get a bathing suit with light designs on it, you can't see it.
Gracie's parents couldn't believe how easy the Mickey feeding tube was to live with. One look at Gracie's life and you can see that the Mickey feeding tube doesn't hold her back at all. So don't feel nervous. The first few times you do a feeding, you might find it helpful to refer back to your care guide. The back page of the guide also contains an information card on which you or your healthcare professional can record important information specific to the Mickey feeding tube and the patient's nutritional needs. Of course, anytime questions come up, you should feel free to call your nurse or doctor. There are a few things you need to do in the way of everyday care of the Mickey feeding tube. Most of it is common sense. In order to prolong tube life and help prevent infection at the stoma site, be sure you maintain the cleanliness of the Mickey feeding tube and the skin around the stoma. Remember to clean the anti-reflux valve to keep it functioning properly. A cotton-tipped applicator works well. Clean the extension set immediately after each use. Wash in warm, soapy water, rinse, and allow to air dry. For flushing the extension set, use the catheter-tipped syringe. When the extension set needs to be replaced, it is available from medical supply sources. The balloon is made of silicone, which can be semi-permeable to some fluids, so the balloon may change in volume over time. Your doctor may recommend that you check periodically to make sure that the retention balloon is still properly filled. It's simple to do. Take the Luer slip syringe that came with the Mickey kit and push the plunger all the way in. Now attach it to the Mickey balloon port and pull back on the plunger. If the fluid that comes into the syringe is less than the originally prescribed amount, detach the syringe, fill it up to the proper amount, and reattach it to the balloon port.
And that's what we
Push
do
the
for
plunger
catheter
in,
care.
and the balloon is now filled to the right
Same
amount.
technique.
The recommended balloon fill volume is 5 cc's. However, your doctor may recommend a different amount. Whatever amount is prescribed, be careful not to overfill it. 10 cc's is the maximum amount. Never use air to fill the balloon. Use distilled water or saline. Never put medications in the balloon. Keeping the stoma site clean is very important, but it is also very simple, with just a few daily steps. Each day, rotate the tube within the tract to prevent adhesions. Clean around the stoma with mild soap and water and pat dry. Your doctor or caregiver may recommend other cleansing agents as well. Be sure to check the stoma site daily for any signs of redness, leakage, infection, swelling, or bleeding from within and around the tube. If you find such symptoms and they appear persistent, call your healthcare professional. Here are a few tips for situations and questions that may arise as you get used to the Mickey feeding tube. If there is leakage around the tube, this may indicate that the feeding tube has become improperly fitted or that formula is being delivered at too high a rate. Check with your healthcare professional to determine the exact cause and remedy. If your doctor recommends replacing the Mickey feeding tube, the care guide provides detailed instructions. Occasionally, the balloon may break, allowing the tube to become displaced. If this happens, contact your doctor immediately. It's also a good idea to have a backup tube the same size as the one that's currently in place, especially on trips and vacations. If a tube becomes clogged, do not insert anything rigid into it, as it may interfere with the proper functioning of the tube. Simply flush it with water. If this does not resolve the problem, consult your healthcare professional for help with declogging. Don't use mineral oils or petroleum-based lubricants on or around the tube, as this may shorten the life of the tube. Always give medications in liquid form. When a medication is only available in tablet or capsule form, ask your pharmacist if it can be crushed and mixed with water. Gracie and her family have learned all about the Mickey feeding tube, and so will you. But the most important thing you'll learn is that life with Mickey is not much different from life before Mickey. That's the goal of Kimberly Clark, protection for life.
I'm not a good kid. I'm not a bad kid. I'm just, average.
Okay, any questions on that? No? Good.
I want to ask you, sorry, I want to ask you if it is painful or uncomfortable.
It's painful to begin with because obviously there's the wound healing process, but once the wound's healed, it's not painful. It doesn't hurt. You can twist it around. Obviously you need to be gentle because it's going to be sensitive, but it's not painful. It shouldn't hurt. So if it does hurt, that's signs of infection.
Okay.
Yeah.
Thank you.
Okay, so obviously training and promotion of best practice. The carers should have up-to-date instructions for the carers, and obviously you should have the training, so that's what this is. But equally, it's that psychoeducation that we're giving to the patient continually, you know, pretty much what they did in that video. It was that constant health promotion piece going on. If you look after it, if you do this, you're going to stop this problem from happening. And there's lots of reasons why younger people would have those. Obviously, there must be an individual care plan. So if somebody has got a gastric tube, you would expect a care plan solely for that. Okay, so it's not ambiguous, it is solely for that. And we'll have a look at some of those shortly. Must have relevant policies and procedures in a work setting. Obviously, with PEG feeding, you should then have ongoing training. So from this, after I've come out and I've done your observations, you'll get a certificate for each of these modules that you've done. They're normally valid for 3 years, but after that, it's then up to you to which ones you keep up to date with and whatever, because the reality is you may only have one customer with PEG or you may not have any. The idea of this course is that at least you've seen it, you've understood it. So if somebody does come up in the future with one, you're not worried about it. You know that you can go online and maybe do a refresher or something. And it's unacceptable for one carer to train another, and only those that have been trained should only carry out the care. So in other words, this isn't a skill that you can teach others to do. This is for you only. And that's because of all the risks that go with it. And if you teach somebody incorrectly and it causes a problem, it will be your fault. So this is for you and for you alone. So to conclude, best practice must be maintained at all times. Carers must take action to ensure good food hygiene and good hand hygiene, and obviously standards adhered when caring for a client with their tubes. Ensure clients' dignity and privacy is promoted. Some people may be funny about it. So again, just talk to them about their routine and what they want. Any questions?
I question myself if the girl is feeling any bad when she sees food, or...
Yeah, I mean, ultimately, there's a lot of psychological things to take into account, because the reality is it does alter the relationship we have with eating, doesn't it? And it's that social aspect and that fulfillment aspect. So again, just having those questions for the people in which you look after, and being mindful of some of that as well. The reality is, like I was saying earlier, that feeling of being hungry, if you've got the gastric PEG and it's going into the stomach, you're experiencing food as normally as you could. You know, it's a normal sensation to have food in your stomach, to feel full. If you're going to skip all of that part of the digestive system and you're going straight into the bowel, that's probably more of an adjustment.
Yeah, but what I mean more is like if her favorite food was tomato, and if she see tomato.
Yeah, absolutely. So I think what's important with any clinical activity is that you can openly talk to the patient. You can just ask them, you know, how do you feel about this?
Yeah.
And the reality is sometimes they want to talk about it. Just nobody's ever asked them the basic questions. And that's the level. And ultimately, what we do in care, we try to be empathetic. We try to think, how would I feel if that were me?
Yeah.
So that dignity bit around preparing that food, you know, and treating their food as if it were food is really important. That behaviour of, you know, even if you bring it out on a tray and you've got a napkin or whatever, to try and give the experience of the illusion that this is normal is where you want to be. If you treat it like a medical procedure, you start to dissociate, don't you? You start to kind of go, oh,
if you are like in train, can you, and your liquid has finished, or I don't know how to say, when you don't have food anymore, can you wait half an hour or?
Yeah. Once the machine is done, it bleeps. So
yeah, I know, but like if you do manually, like, and you are in the train, for example, and you don't want everyone to know you got that inside of you, then can you wait half an hour till you arrive home to?
Yeah. The reality is, with the extended feeding techniques, we use them as people eat in a normal way. It's not you must do it at a prescribed time. The only real bit around the prescribed time is the medication bit.
Yeah.
But if there's medications, then that's prescribed. Food isn't necessarily prescribed. So if you don't want your meal, you know, if you want your breakfast at 10, then have your breakfast at 10. Obviously, the reality is, you know, you'll probably have meds at 7 or 8. So it's about that individual care plan bit, isn't it? It's about sitting down with somebody and saying, you're personal centered, you're the one living with this, you tell me what you want, I'm just going to support you. You know, I'm just going to get the equipment or clean it or flush it. And what I'm hoping, the strong message through peg feeding is hand wash, check the site for infection, make sure it's nice and clean, always flush it before and after each use and clean everything. And actually, it's the same principles of preparing a meal for somebody, isn't it? It's the same principles. You're just going to inject it in through the body. And like I said, as you log on to Canvas, there are the videos there that you can watch about how to do the machine. Again, the machine isn't difficult, but when I come to see you, I will bring the machine and everything, and you'll get to play with that, and you'll see how easy it is, and then hopefully.
It does look easy, but just I'm thinking to the people feeling.
Yeah, absolutely. But that's the same with catheter care. You know, when we look at the catheter bit shortly, it's going to make your eyes water. It is going to be a bit painful. That does hurt. There is that psychological thing going on about, you know, I don't need to go to the toilet anymore, and I don't need to do this, and what do people think? So we should be applying that same principle of care, compassion, empathy to every task in nursing, because a lot of what we do in health is very different to social care. In health, we are doing things that are more invasive. It's very interpersonal. I'm very much in your space. So those people skills and all of the tasks that you see, gaining consent, talking about the procedure, explaining what you're going to do, all of that is the care bit. Actually, the procedures in all of our clinical skills are quite easy. When you start to build it up with that whole I'm looking after a person, that's where it becomes really complex and quite diverse. And just understanding all of that and how people may feel and react to it is what makes us different. That's why we nurse the way that we nurse. So hopefully you enjoyed that. Hopefully you've learned something new there. Shall we have a 10-minute break and then we can move into continence management? Yeah. So if we're back for, what's that, 11:50?
Oh, yeah. I didn't know what's the time. I was like,
Yeah, 11:40 now, so 11:50. All right, see you all shortly.
Yeah.